Thank you very much, Fred, for the introduction and the somewhat daunting introduction. And this was actually a last-minute invitation for me. You heard me introduced, I felt in fairly stigmatized terms, as the chronic speaker at these grand rounds. But I have to say, this is actually the first time I've been allowed to participate in the grown-up section of the grand rounds, because I'm usually limited to the last-minute limerick, which I composed during the break to try to summarize the grand rounds. That's usually the only time I'm allowed to speak. So I'm very grateful for this last-minute invitation. I was very honored until I noticed the envelope was addressed to occupant. Yeah, chronic occupant. Now, this is an academic grand round, so let me say I have no disclosures. I have no honoraria, consultancies, or research grants from the pharmaceutical industry for more than 2 decades now. I'm a clinician and an academic at the Center for Addiction and Mental Health. I do have a financial relationship with Massey College, however. I give them a great deal of money over the years. And I work at CAMH, which is, of course, home to the largest geriatric mental health program in Canada, as well as home to really an international center for research on the experience of immigrants and refugees to the most diverse city in the world. So it's totally appropriate that I have an opportunity to follow the 2 speakers, although with far less content. Now, some of you may be familiar with the fact that the Public Health Agency of Ontario, in collaboration with ISIS, released a report in 2012 on the burden of mental illness and substance abuse in Ontario. And to give you the one-sentence summary of that report, they showed that using the measure of HALYs, health-adjusted life years, which included years lived with disability as well as years lost due to premature death, that the burden of mental illness and substance use in Ontario was 7 times the burden of all cancers combined. That's an extraordinary number. It's an extraordinary statement of burden, and it bears no relationship to the availability of resources for people bearing that burden and their families, let alone access to those resources. Now, I like to try to keep these talks pretty current. So I'm going to read to you a quote from an editorial that appeared this week in the American Journal of Psychiatry. Persons with serious mental illnesses are likely to die prematurely compared to the general population. The excess morbidity and mortality associated with serious mental illnesses results from disparities in health care due to problems with health care access, continuity of care, and coordination among mental health, primary care, and specialty physical health providers. That's the state of the land in March 2014, and really that's the essence of what I'm going to yammer on about for the next couple of minutes. Now, this was an American editorial, but we have very good made-in-Canada data, and we owe some of this to the work of Steve Kissely, now in Australia, but previously in Nova Scotia, where he did research back in 2007 looking at access for mentally ill individuals to some medically necessary procedures. And Nova Scotia, like many provinces, has an administrative database. And we can use these administrative databases to get N's large enough to provide us with some useful and meaningful information. So he looked at the period 1995 to 2001 in Nova Scotia, my home province in some ways, and found that there were over 17,000 deaths from cardiovascular disease, and 2,800 of them were among people who had contact with health services for psychiatric problems. And then he looked at the age-standardized mortality rate ratios. What did he find? It was 1.3 for all psychiatric patients, so that's significantly higher than the population at large. If those individuals had received psychiatric specialty care, their age-adjusted mortality rate ratio was 1.8. So the more likely you were to have a psychiatric problem that required specialty care, the less likely you were to have access to these medically specialized procedures. Last year, my former resident, Paul Kurdiak, who now leads the psychiatric research section at the Institute for Clinical Evaluative Sciences, looked at high mortality and low access here in Ontario to people after a heart attack. And we know that people with schizophrenia in Canada and in other countries that have universal health care, that their life expectancy is 20 years less than the average life expectancy. That is something that we have to grapple with. And if you're thinking, well, yes, they kill themselves, that's not the factor. Suicide accounts for a very small percentage of that 20-year shorter mortality in people with schizophrenia. So he conducted the first ever population-based study of people with schizophrenia to measure mortality 30 days after leaving the hospital after an MI, and looking at within those 30 days, did they get to see a cardiologist? A lot of people would have an expectation that 30 days after you've been discharged from hospital for a heart attack, you would be seen by a cardiologist. So we had a sample here of 71,000 people in Ontario who had had heart attacks, of whom 842 had schizophrenia. The mortality rate in the first 30 days after leaving the hospital was 3.9% for people with schizophrenia and 2.4% for controls. What about getting access to a cardiac procedure, angioplasty or a CABG, or having a stent put in? 24% among people with schizophrenia, 38% among people without schizophrenia. What about seeing a cardiologist? 12% among people with schizophrenia, 20% among controls. And then when Paul turned up the juice a little and restricted the sample to people with schizophrenia based on a hospital diagnosis. In other words, there were some people in this sample who were given a diagnosis of schizophrenia who'd never been hospitalized. But when he looked at the sample whose illness was severe enough to require hospitalization, in fact, the differences became more accentuated. And he concluded by saying, as all research papers conclude, further research is required. You know, I think you shouldn't even have to put that in a paper anymore. Just say yada yada and then get to what you really want to say. Is required to expose the mechanisms explaining both the elevated mortality and health service use disparities observed in this vulnerable population. And indeed, inequitable access to revascularization procedures in people who have cardiac disease and a mental illness is a very I don't know whose that is, a very well documented finding in other populations as well. Closer to Abby Angel's heart is the issue of diabetes and complications among people in Ontario. And here we have Becker's study looking at 1,200 cases of newly diagnosed diabetes among people with pre-existing schizophrenia and comparing them with 3,700 age, sex, geography, and socioeconomic status matched controls. And what did they see? Well, higher rates of hospitalization for infection in schizophrenia, double the mortality rate, higher rates of outpatient visits in people with schizophrenia, and looking at what are some of the reasons that might account for these differences. Is it financial? No, we're in a single-payer system. Is it access to outpatient care? No, in fact, these people with schizophrenia were actually getting seen more often. Could there be patient-level factors, cognitive barriers, or adherence issues in people with schizophrenia? That's a possibility. But what about provider factors? And there is a somewhat neutral-sounding, innocuous term called clinical inertia. And I think it covers a multitude of sins, clinical inertia, and I'm going to come back to it in a paper that just appeared in JAMA Internal Medicine last week. But clinical inertia, time constraints, stigma, lack of training are factors that have been suggested by Becker as accounting for some of these disparities, as well as a fragmented system of care and a lack of integration of mental health care and physical health care. Simone Vigod, a very talented young researcher at Women's College Hospital, has looked at depressive symptoms in women as a determinant of breast and cervical cancer screening. And she published these results 2 years ago, showing that if you had scored clinically significant elevated scores for depression as a woman, you were going to be clinically significantly less likely to have a pap smear or a mammogram. And if this is starting to sound repetitive, it's because these large administrative data studies are concluding with the same results. Now, I'm a clinician, so on a day-to-day basis, I get to see people with varieties of mental illness who do not access the health system as they should for the physical problems that they have. But that's at the level of individual experience, and as somebody wise once said, the plural of anecdotes is not data, right? So you need these large administrative databases in order to produce these significantly positive results. Steve Kissely, who's now moved to Australia, continues to study this problem of access and has looked at cancer-related mortality in people with mental illnesses. This is an administrative database out of Western Australia where he has 135,000 cases of new cancer in the general population over a 10-year period, 6,500 of them among people with mental illness. And here's the striking finding. The cancer incidence was actually lower among people with mental illness than the general population. But the cancer mortality and all-cause mortality rates were higher among people with mental illness, even after adjustments for age, sex, and socioeconomic status. Metastases were slightly more common at initial presentation in people with mental illness, but the difference was 7.1% versus 6.1%, so not huge. Access to services, reduced likelihood of surgery in people with mental illness, and significantly fewer chemotherapy sessions in people with mental illness. And so Steve Kissely speculated, why might this be the case? Well, he said maybe cancer goes unrecognized in people with severe mental illness, although that's actually not supported by autopsy data from Denmark. They aren't full of undiagnosed cancers. People with mental illness receive poorer care, as they do for cardiovascular disease, as they do for diabetes, based on evidence from the United States, Canada, Australia, and Britain. So people with mental illness are in fact less likely to develop cancer, but more likely to die of it, especially colorectal, melanoma, prostate, and breast cancer. Reduced access to treatment for people with mental illness persisted after controlling for the presence of metastases. So it pointed to the need for earlier diagnosis and better access to treatment. Similarly, if we just look at the general prescribing of medication for people with psychiatric disorders, and I'm talking about medications for physical disorders, and Mitchell in the UK has done a meta-analysis of 61 studies comparing prescriptions of 12 different classes of medications for physical disorders. And what I can tell you is that the rates of undertreatment for people with schizophrenia, for all severe mental illness, and for all mental illnesses combined, mild, moderate, and severe, is striking. Now, I mentioned the subject of clinical inertia. And this is actually a small study that caught my eye that was published last week in JAMA Internal Medicine out of New York. And it relates to clinical inertia in patients with uncontrolled high blood pressure and depression. So this is a study of 28 primary care providers and 158 patients with uncontrolled hypertension from 2 inner-city teaching hospital clinics in New York. And the known predictors of clinical inertia as a phenomenon, because this is a phenomenon that has been studied, include age. So this relates a little to Samir's undue pessimism. Samir's probably acknowledgement of undue pessimism among healthcare providers dealing with the elderly. Sex, blood pressure, number of blood pressure medications, number of medical problems, that polymorbidity he referred to, and problems with medication adherence. So to those known predictors of clinical inertia, they added the presence of depression to see if depression itself was known to be associated with clinical inertia after adjusting for all the other known predictors. And 45% of this sample actually was depressed. And the answer is bluntly that clinical inertia was much more common among depressed subjects than among non-depressed subjects. So what did Moyes, the author, call for? Further studies to explore the underlying processes that affect clinician treatment practices when managing a patient with depression. Fortunately, Ben Druss at Emory University in Atlanta has done a huge amount of work over the last 10 to 15 years in terms of trying to come up with real solutions to reverse these disparities. And just this month, he published a randomized trial of a personal electronic health record. And when I say personal, really one that's customized in a collaborative way between the provider and the patient. For people with severe and persistent mental illness. And he did a randomized trial comparing this electronic personalized health record, something we can only dream of in Ontario, comparing that with care as usual. And so subjects were trained up in how to use these personal health records. They were encouraged to access it every 2 weeks. Controls received their typical medical and psychiatric care in the community. This was a sample of people, mean age 49, 85% African American, mostly poor, with a mean income of $7,000 a year, and at least 2 comorbid medical conditions. And what they found was that subjects accessed their personal health record a mean of 42 times per year, and that suddenly the proportion of eligible preventive services, whether it was physical exams, screening, vaccination, health education, jumped from 24 to 40% in the subjects and decreased from 25% to 18% in the controls. So this was a very pragmatic study, but one that tells us that nihilism is not warranted, even when dealing with people with severe and persistent mental illness when it comes to intervening for their health. So I'll conclude by saying that there are opportunities, first of all, for better integration of physical and mental health care. You'll know that at CAMH we recently received $60 million from the public and private sector for a medical psychiatry initiative to try to improve that integration. We have opportunities for better use of technology, whether it is these electronic personal health records or in fact leveraging the power of televideo to overcome the geographic disparities. And I speak to you as somebody who does televideo assessments every week to Northern Ontario, and it is totally user-friendly. I think the final thing, though, is to say that we need to fight stigma and discrimination, because that is the ugly undertone, that is the underbelly that accounts for at least some of this problem. That attitudes among health professionals towards people with mild, moderate, or severe mental illness leads to inadequate access to the care they need and deserve. Thank you.